Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about marginal keratitis. This is corneal photographs of our patient, slit lamp photographs of a patient 28 years old who presented to our emergency with pain and redness in the right eye. And here you can see on examination her inferiorly in the right eye she had marginal keratitis along the limbus with some subepithelial infiltrates over there, which I will explain later on. This marginal keratitis is explained and shown in the blue picture and the green arrows. Another magnified photograph. Here you can see that it is extending from 4 o'clock to almost 8 o'clock, and between this marginal keratitis inferiorly there is a clear healthy zone of the limbus, and then the sclera started. So this is a magnified image of the slit lamp. Another anterior segment photograph. In the cross section you can see in the red arrows it has been explained that it is extending from 4 o'clock to 8 o'clock, and there is ciliary congestion, and ciliary congestion is also more pronounced inferiorly as compared to the superior bulbar conjunctiva. The anterior chamber activity was not that much. Patient's posterior pole, the fundus was normal, the vision was not that much affected, and the main complaint was pain, tearing, photophobia, and discomfort. Yes. Marginal keratitis is basically an inflammatory condition in which the peripheral cornea develops the infiltrates, and later on the epithelium breaks down in that area, in the limbus, along the limbus, and the lesion develops and gets stained over there. This is usually present in the patient suffering from blepharoconjunctivitis, but it is not because of a direct relationship due to the staph aureus. No, it is being considered that it is an immunological type 3 hypersensitivity reaction to staphylococcus over there, as the lower cornea is in close approximation to the lid's margins. And so these immunological reaction develops over there, and these subepithelial infiltrates, which are called catarrh, they developed over there. Other possible hypothesis which we can explain the presence of these things is that the area of the cornea which is near the limbus, over there is a higher concentration of IgG and IgM antibodies along with the Langerhans cells. So because of the high presence, there is antigen antibody reaction over there, which may be associated with the development of this marginal keratitis. But it is usually located inferiorly with a clear zone of the cornea between limbus and this lesion, and it is quite painful condition. As I mentioned earlier, the main culprit is the staphylococcal blepharitis, by lid margin disease like meibomianitis, and along with this Haemophilus, Moraxella. All these can cause this marginal keratitis, but the main treatment for this is to prevent the recurrence of this disease is proper lid hygiene and the treatment of the lid margin diseases like blepharoconjunctivitis, meibomianitis. If you do not treat this, the precipitating factor, these diseases have a tendency to recur. I mentioned that this disease develops with the formation of the infiltrates at 2 o'clock, 4, 6 or 8 o'clock location over there, and once they coalesce, and then there is a breakdown of the corneal epithelium. So basically it is a lid margin related disease. So if you see these patients, if you please observe the lid margins, you will see telangiectasia, hyperemic discs, mildly swollen, medarosis, poliosis, and trichiasis. And if you pluck out these lid eyelashes over there, the scales over there, you will find some mild ulcerations on the lid margins. So basically it is a blepharoconjunctivitis immunological related disease which occurs in these patients. Talk about the management of marginal keratitis. It depends whether there is ulceration or not. If there is no ulceration over there and just these stromal infiltrates, we see usually patients present to the emergencies and ERs. These patients, if there is no ulceration, we can use the steroids. And along with the steroids, as I mentioned, we have to control the eyelid margins and infection over there. We can ask the patient to go for proper lid hygiene, a proper cleansing of the eyelashes with baby shampoos, and along with that we can advise doxycycline oral or tetracycline, azithromycin for the treatment of the blepharitis. Yes, that treatment is very important. And along with this, we can also provide lubricants to provide a soothing surface of the eyelids over there. And erythromycin ointment can also be a good treatment choice for the blepharitis. Yes, this is the treatment in the case where there is no ulceration. But if there is, you see marginal keratitis, there is an ulceration over there, then the steroids have to be used very carefully. And if they have to be used, they have to be used under the umbrella and under coverage of broad spectrum topical antibiotics. And patients should be regularly monitored so that there is no secondary infection over there, no worsening of the condition. So usually this is condition recovers in 2 to 3 weeks with proper treatment. But as I mentioned, they have a tendency to recur unless and until the primary causative factor is treated. While managing this type of the disease, we should also keep in the mind two very important entities which can mimic like marginal keratitis. One is peripheral ulcerative keratitis, that is a collagen vascular disease that has a more aggressive pathway. And in this disease, we usually encounter also the element of scleritis, and it is usually not that much responsive to the topical steroids as the marginal keratitis. The other entity to be kept by the physician in mind is Murren's ulcer. The Murren's ulcer is usually differentiated because in Murren's ulcer there is no healthy cornea between the limbus and the lesion. Yes, there is no healthy cornea between the lesion and the limbus, but in marginal keratitis we will definitely have healthy cornea. So these two entities should be kept in the mind by the physician while treating marginal keratitis. I hope this small presentation will be beneficial to my respected audience in their clinical practice. I want to thank them for their attendance and attention. Thank you.